Well, hello everyone. Welcome. I believe this may be the last talk of the evening on this section here, in our adult section. So we have Dr. Jeffrey Chung. He is the Director of Epilepsy and Neurophysiology at Cedar Sinai. And this is his first time here, so we're very excited to have him here. And so let's please give him a very warm welcome, Dr. Chung.
Thank you. Can you all hear me? Great. So first of all, thank you for a kind introduction and thank you for staying. I look at this room. You are the true believers staying here this late in the afternoon, so great. So today, we've gone through a lot today. You started with Epilepsy 101 overall, looking at just an overview about epilepsy, whether easily to treat it versus intractable, and gone through dietary, how training in epilepsy centers, and also cognitive side effects and surgery. But there are other options as well, and earlier this morning we kind of talked about it. So this is the title, Managing Medically Refractory Epilepsy, When the One is Mightier Than the Life, which my neurosurgeon really hated this subtitle, but sometimes it is what it is. So let's see if this works. Here we go. So I think I would do the presentation kind of walking through some cases or some patients, sort of. If you can relate to it, it's a story kind of like a journey together. I mean, we've heard this before. This is a journey, and honestly, it's a journey that we, medical providers and physicians walk with you. But this is a pretty classic story. A 27-year-old, very young lady, healthy otherwise, just referred for a consultation after a couple seizures, having a second seizure in the emergency room. And nothing that she can remember except she'd bitten her tongue and woke up in the emergency room, so some body's very sore. I mean, it's a common story. It sounded like she had a convulsion and it was horrible. Now, the medical records from the emergency room indicated that she had suffered a witness seizure. She doesn't remember anything, but this happened. And it's generalized tonic-clonic, so big convulsions. Some of the older terms, grand mal seizure is similar, which stopped when EMT came. They gave her IV, through the IV line, lorazepam or Ativan, which would stop in the field. Now, so you went through some of this already in terms of about seizures. We talk about signs and symptoms. There's seizures, and this diagram kind of shows you about focal seizure. When seizures started, essentially abnormal electric signal from one part of area, and it is activating the brain. So it gives you kind of different symptoms. So you have some aura warning, sometimes smell and taste, what we call epigastric rising, the weird funny feeling in the stomach, emotional sensation, if it affects particularly in the amygdala area, in the temporal lobe, visual imaging. So these are information that as clinicians we want to elicit, because the kind of symptoms can help us kind of locate where the seizure may be coming from. You're activating that part of the brain. That helps us. Or if it's in the motor area, controlling the arm and the leg, you can have jerking or shaking. Focal onset seizures essentially means starting from one area. You have this terminology, which Dr. Stern kind of went through it already, where awareness intact or impaired. I mean, if you think of it as a scale. It started with one focal area. You're fully aware, so you know what's happening, which is quite scary as a patient and for the family too. To the point that when it spread wider area affecting our cognition, then you're no longer aware what's happening, so you don't know. And to even wider area involving motor control area in the brain, then you start having generalized tonic-clonic convulsions. Versus a generalized seizure started with all over the brain, so you pretty much have convulsions very frequently as well. So this is a more classic diagram. You can look at it, generalized onset versus focal onset. If a focal onset seizure continues to progress, eventually at the end of the day, you get these grand mal generalized tonic-clonic convulsions. Why does it matter for us to know the seizure onset? Because it tells us the kind of treatment therapy that may not work, particularly. So these are the treatment options. A lot of medications, some phenobarbital and phenytoin. Phenytoin started in 1938. It's still working into some of the newer medications, cenobamate as Dr. Steve Chung always talked about earlier as well. So these are classified, categorized in terms of different medication what we use. But this is actually one of my favorite diagrams because when you look at it, wow, it's busy. But this is how we, as treating physician, we think of it this way. Let's see how we have this. Here we go, perfect. So each of these, you're looking at specifically ways of treating. So some works on sodium channel, some works on SB2A, some work on GABA channels. So as a clinician, when I try to treat a patient, we need to use multiple medications. We want to use it not just one single mechanism. You want to hit it on multiple sides to maximize the side effect. Because especially when you keep on using one type of medication, you're going to maximize really early on. Plus, you're going to see more side effect than anything else. And we already kind of have to talk about it. So this is the way that we think about in terms of medication. A polypharmacy, multiple medication, but logically, based on mechanism of action. So obviously the patient had 2 seizures, so healthy otherwise, but had 2 seizures. So by our definitions and standard protocols, we would have started her on medication. So we started on medication, but 2 months later, she came back for follow-up visit, during which time, in 2 months, she had 3 additional seizures. That's more than what she had before she even came to see us. Very similar though. The seizures are very similar to the previous 2 seizure medications. All right. So this is why we're here, right? This is about neuromodulation. So we're looking at medically refractory epilepsy. And this is probably the one data that everyone uses a lot, specifically, based on the data published back in 2001 in New England Journal of Medicine. So Martin Brody and Patrick Wan in Scotland, they were able to look at new onset of seizure patients and then try to use medical treatment. What you can see is, probably easier to do this, 47% of patients became seizure-free with the first medication that we give them, doesn't matter what. And then if the first medication failed to control seizures, another 13% actually became seizure-free with the second medication. So essentially, a new onset seizure patient coming to see us, we've got about 60% chance making that patient seizure-free with the first 2 medications. That's a really good data. I mean, you feel great about it. It's like, okay, but what happened after that? If the first 2 seizure medication fail to control the seizures, then using a third medication either by itself or in combination, your number's down to 1 or 3%, less than 5% chance. Now you went from, I don't know about if you like baseball, but this is worse than Pee Wee League batting average, less than 5%, okay? What's worse is, all right, less than 5% is still for that particular patient, we're still seizure free. But you got about 36% chance. These are the patients that regardless what medication we give them, the seizure persists. And we heard about all the negative part of it, not just having the illness, right? The cognitive impairment, the loss of time, the loss of life, the impairment of memory, and SUDEP, everything else. This all continues on. So this is something that we need to do something about these patients and basically do something for them. So there are independent predictors. So when we see a patient in the office, we have some. So poor short-term outcome seizure medication therapy. So if you try the first few medications, it doesn't work in the very short term. You pretty much, okay, this is not going to work well with medications. Or if they start off with status epilepticus, meaning the seizure continues on, sometimes required to be in the hospital, maybe even intubation and burst suppression, that's not a good sign. High initial seizure frequency. So if they start off with seizures almost in a weekly or several times in a month, that's a pretty bad sign. Or critical pathological substrate. So there are certain ones that will tell us, okay, well, certain pathology or certain etiologies tend to be worse. So these are clues that we get when talking to our patients and trying to see, okay, what are my chances making this particular patient seizure-free with medications? So our particular patient, we had, of course, MRI, looks really clear. On this, let me show you. You see the arrows and pointing out there is change compared to the other side. you see there is hippocampal atrophy and changes. So this particular patient has a left temporal lobe change. And on EEG, she also has these spikes. You've probably heard physicians talking about spikes and sharps. These are interictal epileptiform discharges. Essentially, they are signs of irritation in a particular part of the brain that increase the risk for seizure. When they keep occurring frequently, they build up into rhythm. That's the beginning of a seizure. So the patient has that. So, of course, you start another medication for the second medication for this patient. So, return follow-up, and then seizure-free for 11 months. Great. You start a second medication. You think, oh God, I mean, this patient is in that 60%, seizure-free, 2 medication. That's great. But she came back after 11 months. And then until 2 weeks ago, she actually had 2 breakthrough seizures. Like, doesn't sound that great. So, and she didn't miss any medication. Great patient, She didn't miss any medication. She's not partying. She's doing what she's supposed to do. So the question is, how often do we see this kind of medication honeymoon, we call, occur? Meaning that you start someone on a new medication, they become seizure-free for a while, and then suddenly the seizure start at 1, 2, and then going back over time. We do. So there's some data. So average time from the onset of epilepsy to the pre-surgical evaluation referral to epilepsy centers is about 22 years from birth. That's a long time. That's more than 1 lifetime. That's 22 years of missed opportunities and missed life. And average latency from the seizure onset to failing the second seizure medication is about 9 years. Now this is, Emperor study look at all Eastern Seaboard. I mean, obviously some patients have a shorter time frame, but if you look at data-wise, 9 years is a long time to failing a second seizure medication. And you notice, this study was done in 2003. In the past 20 years, we have a whole lot more medication. So you definitely can try even more medication. So that number could even get longer if you get honeymoon period. So what happened? We talk about pre-surgical evaluation, right? So talk about epilepsy surgery, the patient comes in. So we did monitoring to find out where the seizure is coming from. And this is a example of what a grid electros is. So a patient comes in, we want to find out if there's a location in the brain where seizure is coming from. Can we surgically remove that? I don't need to go through it. We already had the talk on epilepsy surgery. So this one, if I can show you, let's see. There is a beginning of seizure coming through. Can you see this? Let's see, right here. You see this building up and building up. So this particular patient had a very discrete seizure onset, and we thought we get it great. We know exactly what's happening. But then you have to remember one thing is, for epilepsy surgery, it's different than brain tumor surgery. Brain tumor surgery, there are certain functions that we're willing to impair or sacrifice, because brain tumor, you don't do anything about it, tumor grows and negatively affect the patient, they can die. For epilepsy surgery, the difference is we would never sacrifice any function with a chance of making someone seizure free, because it is important to preserve all the functions. And as I tell my patients, no one can ever guarantee you 100% seizure freedom after any treatment. Right? We use the best data we have. We do the best we can to monitor. So unfortunately, this patient, in her mapping, when I did the cortical functional mapping, she had language exactly where the seizure is coming from. And even when it comes to brain tumor surgery, language is one function that no surgeon is willing to give up. Because without language, without the ability to communicate, we kind of lose a whole lot of health. Brain tumor patients, sometimes they say, my arm may be a little weaker, but I get to live longer. They may consider a discussion between the patient and the surgeon, but language, never. So that's something that we have to be preserved. So this patient, unfortunately, a classic resective surgery, meaning that we know exactly where the seizure is coming from, but taking that part of the brain out, not an option. So switch up a little bit. Another patient, she's nice young 13-year-old boy, had recurrent seizure, frequently increased, and recently has an increase of seizure frequency, came in for a second opinion for us. Now, first seizure was very simple febrile seizure at age 1, which kids can have, which does not, one febrile seizure does not necessarily mean that they will develop epilepsy later on, so we get that. But the second seizure at age 6, again, in the setting of high fever. Now the age is a little older. And then standard seizure medication started, and he was seizure free for 2 years. Great. But then after 2 years, you want to come off medication because, as you heard earlier, cognitive side effect, especially in a young kid, they have to go to school. So you want to try to see if they can come off medication. They did. So seizure free from age 8 to 10, 2 more years seizure freedom. Great. Thought we're out of the woods. And then, of course, seizure returns. So no auras, there's no warning sign whatsoever. And the semiology, the description, the characterization of the seizure was the fact that he would stop behavioral arrest. When we say behavioral arrest, sort of, I'm talking to you and I suddenly stop whatever I'm doing. And that's a behavioral arrest. And then very frequent generalized tonic convulsions. So frequency, about 3 to 4 seizures a month. That's a lot. And risk factors, none really. I mean, except those 2 febrile seizures, nothing else. No family history of seizures. And we did an MRI, was completely normal. And we hook him up to EEG. What you can see is the seizure looks like very diffuse. Left side and right side of the brain, all over. Maybe a little bit leading on the left that you can see on the blue color, but otherwise, pretty generalized. So, seizure medication we tried before, oscarbazepine, or trileptal, no change in seizure frequency, didn't help. Phenytoin dilantin actually make the seizure worse, got more frequent. Toprimate, we talked about Topamax earlier, no notable changes at all. I mean, the school performance got worse because of the cognitive impairment, and makes it hard. So current seizure medication, valproic acid, Depakote, had the longest seizure freedom at age 10 for about 15 days. That's pretty sad when your longest seizure freedom is 15 days. That's just 1 day longer than 2 weeks. And gradual, of course, because of side effect, medication effect, gradual weight loss, or weight gain, sorry, was huge. And then also niacinamide and lamotrigine. So we decided to actually do genetic testing, and this patient actually had an SCN1A variant, which is a Dravet variant. So Dravet syndrome is characterized by a channel mutation in the sodium channel, so that all sodium channel active medication actually potentially can make the seizure worse. That's why I'll go back to the early diagram that I showed you. We kind of need to know the mechanism because certain medications are not good for particular patients. So, wow, the patient had generalized looking seizures, had a genetic mutation. So you can think, let me look at one part of the brain that's causing seizure to take it out surgically, probably not a good option. So, and then the patient comes in, 30-year-old young lady, history of seizure for 5 years now. Still continue having seizure, obviously, so came in for a second opinion. She got this fearful sensation, and then and they can happen just so they get the aura, the fearful sensation, but didn't have seizure coming afterwards. The semiological characterization is that they have the aura, and then with the behavioral arrest, which I kind of demonstrated earlier, and then repetitive picking and close, and occasionally have generalized convulsions. Now, for people who don't deal with or don't quite have the experience, with patients or themselves or with family members with the auras, aura itself is quite disabling as well, right? Yes, it didn't progress into a seizure, it didn't affect them, they still can think, but it's the constant living in fear that, is this the aura going to lead me to have a seizure? That is stressful. I mean, so one of the things that I think I learned from my old mentor was the worst thing about epilepsy is in between seizure, it look pretty much is fine, but it's that 15, 20 seconds, 30 seconds, 40 seconds when you have no control over your life and your safety, and you never know when that's going to happen. Living in that, that's probably the worst aspect of it. think of it like kind of like an earthquake versus a hurricane. Hurricane, you get told 4 days ago, you try to pack up. An earthquake just comes. So it's sort of not a very good analogy, but that is sort of the living in fear of the fact that we are out. In LA, we live in fear that the big one's going to come, but we got used to it. But patient having seizures, we can never get used to that. So remember that. So the frequency, 2 seizures in the first year, not that much, but then increased to 1 seizure every 2 months. Last year, 1 to 2 seizures a month. That's a lot of time. That's a lot of time because that patient, it's hard to hold a job when you have this many seizures. Yes, there's American Disability Act, there is all the protection, but at the end of the day, many patients have lost jobs because of seizures. And there are still, as sad as it is to this day, there is still that stigma. And so living a normal life is really difficult until we can actually help them get things controlled. So risk factor, again, not much. No head trauma, no, just 1 fat bowel seizure, age 2, nothing really. And then we did an MRI, looks completely pristine, nice and normal compared to the previous patient that we were talking about. And if I kick this, let's see, here we go. Oh, no, the animation didn't go through, but you see there's a little shot right here. So there is some abnormalities that looks like on the right temporal lobe that is possibly seizure coming from. So the patient came back after 3 months, which she had 3 more seizures. Again, not controlled. What can we do? So the patient underwent electrodiagnostics. We have a phase 1 EEG. This is a phase 2 invasive monitoring because the MRI is normal. We put in depth electrodes. You've heard about that. And what we see is, let's see if I can put this down. Let's see, this would go. You see the arrow pointing, the seizure coming, starting in the left mesial temporal lobe. So that is the left amygdala, the most middle part of it. It's classic. But remember, the previous EEG, the routine EEG shows were right temporal chops, but seizure coming from left, like, okay, what happened next? So it continued to build on. You can see the seizure, the rhythmicity kind of builds up. And then it starts going to the other side, the right side. And then now, even our neurosurgeon can read that, right? You can see the build up right here onto the right side. So this patient has seizure starting from the left to jump to the right, and the right can independently carry out having seizures. Now she's got both sides temporal lobe can generate seizures. We kind of need our temporal lobes because the most middle part of temporal lobe, the hippocampus, where we lay down memory. For patients with long time seizures, sometimes the function gets transferred to the contralateral, the opposite side. So you can remove one because it's not going to affect memory, but you kind of cannot take out both. We did that back in the 50s and realized that the patient cannot form memories anymore. So we kind of stopped doing that. So this continue on as you see how big. So, and by the way, these patient cases I'm describing to you, these are actually patients that I've taken care of over the years. And this is a 40-year-old gentleman who had left temporal parietal resection. So they took out the left temporal parietal part of the brain because of basically refractory epilepsy, and then came back after 12 years. New seizures are very similar. So he was seizure-free after surgery for a good amount of time, almost 12 years. And then the new seizures now coming back, obviously. That's why I kept seeing them again. And very similar to the previous before surgery. Medication has been enough. 12 years seizure-free, you figure earlier on you would. And typically, if you have a question to ask about it, is sometimes, classically, we would like to wait about 2 years after surgery before we start taking off medication. Depends, and there are times that there are choices too. Some patients realize that I don't like medications, but my final seizure-free. I don't want to mess up with anything else. But also part of the problem is, especially living in Los Angeles, you finally get to drive, and then when you come off medication, and then afterwards, you get 3 more months after you're off medication, you shouldn't be driving. So they finally get a job, they cannot. So there are other reasons that they choose not to come off medication at the time, but typically would be. So this patient was off medication, but seizure came back after 12 years. So what can we do for these patients? Because we heard about it, all the cases I've told you before is we cannot really do any resective surgery, and medications have not helped them. So that brings to what we want to talk about today is neuromodulation. That would be the other options. So to this day, the mainstay for neuromodulation, essentially you are based on device, and the device have vagus nerve stimulator, response neurostimulation neuropace, or deep brain stimulator by DBS, which we use. It was originally studied, so DBS been around for a long time, but for Parkinson's disease, Medtronics, but for epilepsy was more recently FDA approved. So I showed the diagram for that. So now, in terms of neuromodulation, we're looking at extracranial modulation, so outside the brain. So no implant in the brain, so VNS would be, in our case, vagus nerve, so it's outside. Or targeted stimulation. So targeted, you're looking at a specific area of seizure onset and you want to stimulate that area to modulate. So response neurostimulation, RNS, would be the option for that. Or you do network stimulation, meaning that perhaps you don't have a very specific target that we found, but we believe the seizure travels through circuitry, oftentimes through the thalamus, which is more recent. So you can actually target the network. So DBS was designed for that target network stimulation, which RNS now do have looking into, it's still a stimulator, can we target the network? Versus complementary therapy would be our last patient I just discussed, a 40-year-old gentleman who had surgery, and 12 years later, seizure came back. So now he already had surgery, what are you going to do? So you can consider utilizing these neuromodulation to help alongside to see if we can get the seizures back under control. So we'll talk a little bit about VNS. So VNS is the first device for epilepsy. It was FDA approved, been used for a long time. Over 100,000 has been implanted now. Almost annually 10,000. That number changes depending on which study you read. But a lot of times what we see is actually the only one that is extracranial. You see the picture here that you have a generator over the chest, wire coming through, and then basically wraps around the vagus nerve. The thought process, to this day you figure, God, this is the oldest one, you should know how it works, right? Truthfully, we don't. What the thought process is, with the electrical stimulation of the vagus nerve, there is upstream stimulation and modulation. What it changes is neurochemistry. So the change in terms of neurochemistry, it goes to locus coeruleus, different parts of the brain, but it changed the neurochemistry such that shift in balance helps control seizures. But because it actually changed some of the neurochemistry that actually, serotonin, which is one of the areas that antidepressant targeted, it also helps with depression. So this is also a unit that has since been FDA approved for depression. So what is unique about this is, again, it's extracranial. So it's outside the brain. You don't have to have any brain surgery for it. And the drawback with that is obviously you can imagine you do the stimulation of this nerve or what it's going to do. The vagus nerve, most people don't feel anything. Sometimes they may have slow down heart rate, but the more complicated is the fact that the vagus nerve is really near the recurrent laryngeal nerve. So recurrent laryngeal nerves are actually attached with when we speak. So when it does the stimulation, and when the patient's speaking, you can hear the voice kind of slow down, get deep down. So I would tell my patient that you sound like Barry White every 5 minutes or 3 minutes when we depending on how we said it. I love Barry White, but not everybody does. So, but that's there are physical drawbacks. When it comes to neuromodulation, what we also know is that you have to do this gradually. You cannot just turn off. It's not like turn off, step the gas, let's go 100 miles an hour. It's not NASCAR, it's not Formula One racing. You gotta do it slowly, because remember, this is electrical stimulation. So if we go full force right away, you're going to impose discomfort. And the worst discomfort will be pain, obviously, with stimulating. So we have to do it gradually to increase. But what neuromodulation like VNS has is different. If you look at numbers, you think of it as a form of therapy, just like any medication. But by the very nature of the fact that it's not a medication, it doesn't have the cognitive side effect, meaning that it doesn't make people tired. It doesn't impair their thinking process much, right? So what we've used to be able to add on to it is, again, complement. Like when we talk about using medication, use different mechanism. Well, we try everything we could. So modulation would be added therapy, but without the added side effect in terms of medications. So, it's good efficacy, even though it's FDA for focal, but we've shown that it's really good for primary generalized seizure disorders, then like Gestalt syndrome, and also drop attacks. So, previous to VNS, drop attacks patient with specific syndrome that they actually fall, which, since we're all top heavy, when we're patients with drop attacks, they tend to head fall first, so there's a huge amount of head trauma. Collosotomy, cutting the corpus callosum. This is basically cutting the connection between the left and right brain until the anterior two-thirds, cutting it. That was the treatment of choice because it's effective. But with VNS, it shows that it actually is effective for drop attack seizure. So you can imagine what we cut, we can sew back, not your brain. So you rather implant, the first choice would be do the VNS first. For patients who still continue to have drop attacks, obviously, then we can go back to a surgical corpus callosotomy, but you rather implant something else first, right? So long-term effect, what we've seen is, also this is actually interesting, until probably about 10 to 12 years ago, many of these devices were not looking as great and promising. Part of the reason is we didn't know enough about them. We designed them thanks to the engineers, but engineers didn't treat patients. So the clinical trials for these devices were based on medication. And if clinical trial for medication, you're looking for effectiveness efficacy within a 3-month period, 2 months, 3 months, or even 6 months overall. What we didn't know is for neuromodulation to work, it actually goes beyond 6 months. So you need to look longer. So the trials really should look at 2-3 years and then out. So this is a over 10 years follow-up. We've seen for VNS, you have a mean reduction about 55.8, a little bit almost 56% mean reduction in seizures, which is not perfect. You look at most medication, you're looking at somewhere between 50-60% now, especially the newer generation, the second and third generation. But again, it doesn't have the side effect of medication. It doesn't make patients more tired. In terms of the prospective long-term efficacy, we've seen the red line right here is best medical practice, but if you use VNS, it actually drops down to minus 21%. So it does help quite a bit. And I go to the next page on this. So other things we look at. So the newest generation of VNS also look at a few things. In the past, you may have heard of the term open loop because it was not, VNS was set up every 5 minutes, every 1.1 minutes, 3 minutes, every 10 minutes, it's going to stimulate for 20, 30 seconds. How you set it to try to see if we can help the patient. But there is, if the patient feels an aura or seizure coming through or the seizure starting, either the patient can or family can just swipe a manner to do an additional stimulation to try to help. But that is really depending on the patient and the family member close by to do that. In the newer models, they actually have, what we've seen is about 80% of the patients, 82% of the patients actually had this sudden increase, what we call tachycardia, sudden increase in heart rate when the seizure is coming. Some may be a little earlier, some may be a little later. So what we did is with the VNS, they have an additional wire to look at heart rate. So once they implant it in the operating room, we get a resting heart rate. And then we set the auto simulation. So now the unit recognizes if there's a sudden increase in heart rate, and we can set it 30%, 40% above the resting heart rate within a short period of time, then you do an additional stimulation. So now it is a closed loop because it's responding to the heart rate change. So what is helpful, particularly with the auto stimulation? You don't have to rely on the patient knowing, because sometimes as a patient, you know the seizure's coming. By the time you know it, you already lose awareness. You can't do anything else. So imagine trying to grab the magnet to swipe, not going to happen. And sometimes, sadly, because magnets are everywhere, you can't, as a caregiver family, you can't get to the magnet. You miss that. But the auto stimulation allows that to help it to, and it automatically it would do the stimulation. But what's actually useful is when we do the programming, when we check it, interrogation, we can see a trend, and I can take it in terms of by day in a 24-hour period when are the seizure most frequent versus in a month when the seizure most frequent. What I've used a lot more in terms of day, because I know some of our patients tend to have seizure breaking through right before the next dose of the medication, a little than an hour or so before. So what we can do is we can kind of adjust dosing timing. Maybe I need to make it 3 times a day, or I need to shift some of the medication earlier. So that's something that trending aspect of it does help give us a little bit more information. Modify, as I said, modify here, seizure medication dosing schedule. The medication reductions, we kind of, earlier there's a gentleman came by and asked, so what if the VNS, we can implant the VNS and the patient do well? And I have patients who did very well, and I have patients who basically said, this thing's the worst thing I've ever had, please take it out of my, I have, after 25 years of doing this, I can see both spectrum. But for those patients who have very seizure well controlled, and what you can do, and what we've done is actually start cutting back on some of the medication, because no matter how great, how new, how expensive a medication we prescribe to you, it's still chemical. So it's going to have some side effect. You may not feel it, or a patient may have just get so used to deal with it, the fact that they just don't complain about it. But at the end of the day, it's still chemical. So if you can use less, it's better. Unfortunately, I'm pretty conservative in that respect. I would like to have less medication. So we have patients who had implanted devices, and then when they do well, we start cutting back on medication after a certain time, and then they feel better. I've also had patients who are unfortunately very debilitated. They had severe head trauma after accident, so they're seizure frequent. With medications, they're really just not even interactive with anywhere else around. With the VNS, we're able to help maintain the same control while cutting back on the medication, so they're more interactive with surroundings. So that's something that we can definitely consider doing. Now, the next neuromodulation we can talk about RNS, neuropace. So this idea is more started from the fact that when we were doing cortical brain mapping, because we're sending electrical signal to the brain surface around the area of seizure control to see if there's function there, we inadvertently actually stimulated bring out a seizure. So what we were able to do is do a quick finger, trigger finger, do a quick stim within less than a second to try to break off that chain of building up and stop the seizure. That was the idea of it. So you can imagine it's meant for very targeted to begin with. So you implanted the battery, as you can see on here, at the model scalp. And you can either do a strip or depth electrode place into area where we believe seizures happening. So that patient that I mentioned earlier, with the very first patient who happened to have language where the seizures coming from, this would be an ideal therapy for them, because we can't take out the language area, but I can definitely do some modulation, stimulation, break off the seizure from happening. The other patient happened to have seizure coming from both sides of the brain. This is also perfect because we can't take out both sides of the brain. So neuromodulation is one option to do. So when you look at data, this is as time goes on, we can actually see go over to higher, getting up to about 70% when we look at the modulation. Again, that's why the earlier clinical trials were not showing very promising result or super great result, because we just given it long enough time. And when I show you this diagram, it's, again, looking at year 9, look at this number, it's almost at 70% seizure in terms of responder rate. So 70% of patient is showing a good response to seizures. Have I had patient who actually became seizure free? Yeah, I did. If I have a patient who's still having a difficult time, we're still working with them. So this is it takes time. One of the hardest thing about the NeuroPace or RNS would be the data that we collect, because it reads the EEG continuously is safe. But the technology started from the 90s and 2000 when we were doing clinical trials, so you can imagine there's not a whole lot of memory in that little thing compared to nowadays. So downloading the data gives us the information about when the seizure is happening, so we can train the unit to recognize the seizure in order to do it, to control it, and it has been great. So this is sort of the recording that we've seen before. We have these little spikes that you can see on here. So, and now we're seeing seizures coming through left and right side. So continue on. And this is also how, when there is stimulation, seizure coming through, and we do stimulation and breaking up that buildup of the seizures. So the next one, this is a good example. We have seizure building up, and after stimulation, nice and flat, quiet. Now there are different types. When we look at the data, the unit recognizes the seizure we call long episode. And certainly I have patients who now have still long episode but aborted by the RNS, which patient never felt that she has seizure. That's great. We also have patients who no longer even have long episode because of modulation work enough. The fact that all we have is scheduled recording, which is great. So on a long-term base, you can actually train this data. You can see in the beginning, you have a lot, this is starting in December, let me just read, June 2021 implanted, initially some seizures going through, but starting about February 22, all the way to now, at the end, that trending data is very little. So there are some patients who are not really having any seizure, even geographically, forget about clinically. So that's great data, and that's the poster patient that we would all love to see. Now, one thing it also helps us is, because this is implanted, is continuous recording. So it gives us longer term data in terms of intracranial recording, seeing the seizures coming from. So for that patient that I mentioned earlier with both sides, seizure coming from both sides, if you've gone through this monitoring, this is a somewhat artificial environment. We bring the patient in to the hospital within and try to do it in a week or 2 weeks. We drop the medication, bring out the seizure. It's not at home. So sometimes we've seen, after implanting the NeuroPace, we've seen over a year, 2 years time, you had 99% seizure coming from one side of the brain versus 1% coming from the other. So are those patients a candidate for actual resective surgery now, because you really have that huge discrepancy? So that is also an option. So I have patients who decided, take out the side that is having a lot of seizure, we'll leave the one that having 1% seizure, still doing the modulation. We can do that. And I've also had patients say, I'm seizure free. Whatever is working right now is great. Don't touch anything. I'm fine. Okay. So there are choices, but my goal is to make it, give the best chance of making a patient seizure free, so he and she can go live his or her life. And that's the whole point. That's why we're doing this. Again, also, of course, when the patient who's doing well, after a good time, enough time that we know that this is working well, we can start reducing medication. Again, trying to limit the side effect. DBS, deep brain stimulation. So this was again designed originally for Parkinson's disease. We're looking at the thalamus, but we're now looking at anterior thalamus or central median thalamus, different areas of stimulation, because we're looking at, can we affect the network? If we can't tell you, we can't find out where the seizure is coming from specifically, but we know how it travels. You block off the traveling, that pathway, you can still break off the seizure from spreading all over to control the seizure. So that's the idea. So what we've seen is, again, with looking at the study, you see the patient received it, actually got a reduction in terms of seizure frequency down to, and then I'll show this. This is a median reduction is, I'm sorry, my eyes are getting out. Median reduction about 69%, which is a pretty good, almost 70%. So if you give it long enough time, you get better data you can see. But obviously, there are patients who responded really well early on, but overall, we do expect the modulation to take time work. What exactly is modulation? So we talk about aborting the seizure with electrical signal, but when you routinely send an electrical signal in the part of the brain, you change the way the network, you change the way how these electrical signals spread. And by affecting that network, changing the way they spread, it can impede seizure from happening, spreading elsewhere. So clinically, it doesn't affect the patient. That's what we like to see. So now with DBS, this is the newest kid on the block, so to speak, for specifically for neuromodulation for epilepsy. So we're looking at, there's the field potentials, long-term field potentials, and local field potential to see. And this is a patient of mine who actually had more significant one side than the other. She actually had, went through, all the evaluation, even with the MEEG, that it would look like seizures deep in the brain, but we know the exact location. But when we had electrodes in, it looks so widespread that there's no way we can do resective surgery. So with DBS, we're looking at it. She does have more focal, so we can use that data to help us trend to see if we can adjust. But it is a bit newer in terms of looking at the field potential and looking at disrupting the network using neuromodulation, where RNS also is one way, the neuropace earlier, because you can implant electrodes into these areas, the thalamus in different areas, in order to try to work with modulation. The difference is the recording looks a little different, so we adjust ourselves to learn to try to make that change. The next thing I'm going to talk about, this is not FDA approved in the United States. It is approved in the European Union. It's trigeminal nerve stimulation. So it was actually invented by Chris DiGiorgio at UCLA, now in Olive. So we're looking at the trigeminal nerve basically have multiple branches in the face. And what it projects to the vagus nerve, and the idea is, well, it goes to the vagus nerve, we do the VNS, vagus nerve stimulation. Can we just do that externally? Now, this is a wearable type device, so it's not implanted in the brain. You just wear it at nighttime and do the stimulations. It's non-invasive to be used at nighttime. So what the early on data shows the fact that, non-invasive device about 12 to 16 hours at night while asleep. That, I don't know about you, but I can never have a 12-hour sleep, let alone 16 hours sleep at nighttime. I wish I did. I get about 4.5 to 5 hours a night. But that's going to be hard to do. It's adjust the comfort level. I mean, you can adjust in terms of level, but 50% responder rate, meaning that 50% reduction in seizures, about 42%. Not as quick as the 69, 70%, but this is still early on data, so the longer you may see that. But also this is a device that is not implanted inside the body anywhere. You have to just wire it. So what's good though is that, I mean, we don't know what the status is. It is approved in Europe. It's also used for depression because it's similar for the VNS. But also, I've seen it, you can actually buy the unit for migraine, which I bought my wife, but she never used. So because she said, I treat seizures, I don't treat migraine. So she doesn't trust me about migraine treatment, which I get it. I understand that. I respect that. So I kind of go over a few things in terms of neuromodulation. So, and I would say that one of my patients with RNS neuropace was somebody that I first saw even when I was back in faculty in Florida in 2005. And at that time, it's a very similar story. Her seizure onset area was specifically where the language is. So I said no, but it's not right now, because I don't have any good option for you. We were at the time actually a clinical trial site, but she actually lives out here. She flew out to Florida. You can't keep flying back and forth for that kind of, I mean, at that point, talk about 20 years ago. I mean, that's a long time ago in terms of the technology wasn't quite right for her. But she has since got implanted and she's seizure free, has a baby, and living her life. So I would say that I never give up hope, because no for now doesn't mean that no forever. Technology is improving, and that is one patient that I can say. And then the patient who had seizure come back, not all is lost, new technology. So that patient went up, we did monitoring, we did strip electrodes around the area of the previous resection in order to try to get better control. Because what we did was that patient was operated on, we did back in 2002, and we mapped that push up the closest area, so already getting to the visual cortex. So the more I cut, he's gonna have problem with her visual field. So we couldn't extend anymore. So that's why we use neuromodulation. So don't give up hope, because there are always technology. In terms of the future, I would say that we want to get more precise location, so we're not taking a whole chunk of brain. Using different technology we can do, better understanding about how seizures spread, because so talk about the network. So we can't figure out where it starts. Okay, well, if I can, I can stop it from traveling elsewhere to actually manifest as a seizure, I can still do that, right? And then less invasive methods. So we talk about laser ablation earlier on, their focal ultrasound therapy in terms of lesion, or trying to do a very small area, take out the lesion so that we don't affect as much of the brain. I mean, the brain is really important, as I know. So in neuromodulation, as I said, different technologies do come out, and infusion biological therapy, there's stem cell injection, we're all looking at all different areas and try to help. And at the end of the day, it's not just one thing. It's probably a combination of these technologies and these therapies in order to help our patient become seizure-free and with minimal side effect. I want to emphasize that side effect is not something to be dismissed or to look likely, because I always say I can make everybody seizure-free, but then they will be in a coma. That's no way to live, right? So managing side effect and maximizing the results would be important. So I think I've outstayed my welcome. It's pretty late for all of you guys, so if you have any questions, please. Pretty quiet. Oh, yes.
With the
TNS, the trigeminal nerve stimulation, yeah.
Has that been used in conjunction with the VNS?
So they were studying in Europe. I believe they did. In the US trial, they were excluding other devices, if I remember correctly. In Europe, they have done additional one, but because it's not FDA approved, it's not in US, so I would prefer to wait a little longer in order to see more phase 3 trial to see what their parameters are. Nothing against Europeans or anywhere else, but the FDA is pretty tight and pretty stringent in terms of the way approving certain devices, even in trial-wise. So it's held in a much higher standard.
I guess my question is, would it hurt? Because a quick look on that, they definitely have them available for migraines. They have
Right.
them available to help with ADHD.
Mm-hmm.
But as you said, it's not approved.
It's not approved in the US, and there's a reason for it. In terms of the migraine, I couldn't tell based on because it's over the counter, it's not even a prescription based, right? So I can't tell you in terms of their parameters what that is, and is that parameter set, because stimulation is not all the same. You look at different frequency, not just the frequency, but the duration, the pulse width, all those. So maybe same device, but it could be different parameters that's meant for different illnesses. So I would caution by utilizing off market. But overall questions, is it possible to have multiple devices? Yes, because you can manage. VNS was the first one that came out. So many of these patients that we have already had VNS, but then it didn't quite work. New technology came, so now I have a combination patient with VNS and DBS, VNS and RNS. It's a whole alphabet soup, but they are not contraindicated with each other if you do it properly. But then the key, as a patient, as a family, as a parent, have the patient evaluated at a comprehensive epilepsy center, knowing what are the options, risk and benefit. That's the key to do. Do I have patients who say, look, let me just take out one, because do I need to go through with this many devices? Certainly. I mean, I think that's once we can get control, then we can look at. But most patients end up getting rid of some medication because there are usually 3 or 4 different medications, and the side effect of medication was worse than the devices, so one peeled off. So do I have I mean, I have one patient who's had a VNS who is no longer on seizure medication, but that's 1 out of 25 years. That's not the one that I would say, yeah, everybody can get that. Like, you get that when you're like, yes, but in between is, I mean, even if you're on some medication, but not cognitive being impaired, not being so tired, you have a device to help control, you can go live your life. I mean, that's more mainstay. Any other questions?
Regarding the surgery implant, how would you compare the RNS to the DBS as far as the surgery goes?
That's more of a surgical question. For the RNS is, well, DBS usually takes 2 separate surgeries to implant the electrodes and then the stimulator battery. RNS is usually one surgery implanted. I think that's, in terms of timing wise, also surgeon dependent. Sure. Any other questions? No. Yep, yes sir.
Do you have many patients that have VNS and DBS?
Yes, I do. So,
How's that working out?
I mean, she is a patient that we actually thought that with the MEG we had really good seizure onset area, but then it turns out that it's still broad. So she's a patient who came in for our monitoring unit. She had 285 seizures within a 4-night period. I didn't even touch her medication. Some she didn't even feel. And after implantation, we were able to reduce her seizure frequency just electrographically, the ones that she didn't feel, by 2/3. Now recently I saw her seizure got a little worse, so we're changing things around a little bit. So it's still work in progress. Yeah. Yes, sir.
So you got some with RNS and DBS together?
Not RNS and DBS, VNS and DBS, or
Okay.
VNS and RNS. Not sure, because they're both intracranial. That's something I haven't come across that to that point yet. Because usually I don't think it would, because when we make a decision about intracranial, it's going to choose between one or the other. And so it really depends on whether we're looking at purely network, or we're looking at targeted or complementary, or network using RNS is a way of getting a little bit more recording that we can understand and try to go through. Yes.
Let's say you implant either the DBS or the RNS, well, those two, or either one, and it doesn't work. Do you have to go back and take the leads off and the RNS?
The battery and all those.
You have to take that out, or would it just stay there and just turn it off?
You can stay there and turn it off. I mean, it's a surgical procedure. You can remove the generator. Usually, let's say, so far, knock on wood, I have not had actually for RNS. The patient who needed to be removed was because of complications. We had meningitis, so okay, you can't have it indwelling. When you have infections, you cannot have indwelling foreign bodies, so that's the reason we're talking about. But in terms of, because of not effective, no, I have not had any patients who are not effective had RNS or DBS pulled out. But I would say that for VNS, we would just take out the actual unit, the battery, but the wire, most of the time we just leave it there, because you gotta remember the wire wrap around the nerve. So to unwrap it, not many surgeons love to do that. I mean, one of the things that we've been pretty fortunate. We have pretty good response with some of the neuromodulation, because we do our monitoring to exact the location. So for targeted neuromodulation, we know exactly where we need to go after, just because we just could not remove that part of the brain because it's not safe for the patient. That's the reason. So, but and I'm hopeful that as technology goes, the battery life lasts longer, the recording time lasts longer, and less intuitive, or even more technology, we can actually do more combinations. So we'll see. 20 years, 25 years doing this, and hopefully in the next, I won't say 25, that's a long time, but at least the next 10 years give me a little bit more options so I can help my patients. Any questions? Thank you so much. I know it's 30 minutes.